Hello, my name is Michelle Lavelle Henry, and welcome to the Social Justice Forum. Our theme this year is Wading in the Water, Becoming Anti-Racism. Today, we explore health equity through the lens of COVID-19, and we have three panel experts, Doctors Miguel Ruiz and Cristina Plaza Ruiz, as well as Femi Banjoko. Let me introduce each person. Miguel Ruiz is a Health Partners Hospice and Community-Based Palliative Care Medical Director and member of the palliative care team at Regions Hospital in St. Paul, Minnesota. He is involved in several equity and palliative care efforts and projects through the years. He currently co-chairs Regions Health Equity Committee. He practices internal medicine, hospitalist over 15 years at Regions Hospital, where he also served chiefs of staff 2014 to 2015. Earlier in his career, he was an internist at the West Side Community Center, and he founded the HIV primary care program, which serves Latino and other communities of color. He is an expert in the area of advanced care planning in diverse communities, a member of the board of directors of the Minnesota Hospice and Palliative Care, and a member of the Minnesota Honoring Choices Advisory Council. Cristina Plaza Ruiz practices as a bilingual Spanish and English psychotherapist at Health Partners for International Health and is an adjunct professor at Bethel University, both in St. Paul. She has clinical expertise and ample experience providing psychotherapy, family education, and counseling in culturally diverse settings. She places an emphasis on supporting families as they can adjust to new cultures and environments. Those who are processing through immigration, who have had trauma or loss, and accompanying life challenges. Cristina balances her clinical practice with interest in higher education, particularly training teachers for social justice at higher education levels for many years. Currently, she is adjunct assistant professor in the Marriage and Family Therapy Master's Program at Bethel University. She received certificates from Harvard Program in Refugee Trauma in 2019, earned her doctorate in leadership and higher education. She holds a master's from Hamline University and a postgraduate certificate in marriage and family therapy from Bethel University, or Bethel Seminary. Femi Banjoko is a geriatrician specializing in elderly with interest in palliative care and holistic medicine. He sees his role as a personal advisor. This philosophy empowers patients to take control of their health. He feels the best outcomes are achieved when patients work together with their healthcare team. As a geriatrician, he finds this approach especially appealing to older adults. They often have good insight into what works for them. All I must do as a physician is be patient and sit back and listen. He received his medical training at the University of Lagos, Nigeria. He is board certified in internal medicine and geriatrics. He currently practices with the Park Nicollet Healthcare System in St. Louis Park, Minnesota. Welcome, our panelists.
Thank you for giving us the opportunity to share on the topic of health equity and COVID-19. This is a topic that has rapidly become a critical and central aspect of this pandemic, not only in the healthcare arena, but in the public and national and international spheres, as it has exposed deeper fundamental political and societal issues affecting our global community. Just let me share with you that I'm very excited to be here with Dr. Banjoko and Dr. Plaza Ruiz, estimated colleagues of mine, and Cristina, my wife, so a special type of colleague. But we really are excited to share with you some of our experiences, and we will briefly describe some terminology and give some basic statistics, and then move on to some of the specifics about how COVID-19 has affected diverse communities, including their mental health. And then from there, we like to propose some ideas on how to advocate for health equity. And we hope that we have time for some questions from you as well. So let's see if we can move this slide here. Sorry about that. Simply put, health equity means that everyone has a fair and just opportunity to be as healthy as possible. That's a simple definition. So equity is not so much about equal allocation of resources, but rather it's about the provision of resources and the interventions that will make it possible for all individuals to achieve the desired positive health outcomes that we want. And to do that, as you can see in this cartoon, we need to provide in different individuals with a different set of assets and services. And we, those of us who practice medicine, we know how different it is in the hospital, for example, to care for a 24-year-old with COVID-19 than it is to care for an 80-year-old patient with the same infection. Obviously, the older, the more resources, the more assistance. So patients who, for example, don't speak English, which, by the way, were 50% of the patients we were seeing at the end of May with COVID-19 in my hospital in St. Paul, were actually non-English speaking. And we'll talk more about this. So this is, please remember that equity and equality are different. As we talk about this issue of health equity, we cannot ignore the fact that we are living days of major demographic trends, which are striking. Actually, this year, for the first time in the history of our state, Minnesota, we are going to have more people over the age of 65 than children of school age. And this has never happened before, and this is happening this year. And actually, this is not going to happen in the US as a whole until 2035. And as you can see on the yellow line here, the trend will continue over the next few years. So that basically by 2060, the US will look like Japan looks these days, which is a society with more than a quarter of their citizens over the age of 65. When we look at another major demographic trend, we see here another striking reality, which is the increase in diverse populations. And I'm moving, hopefully you can see the whole slide. Can you now? Thank you. This is an important consideration, the fact that if we look, for example, at the distribution of children by race in our country this year in 2020, more than 50% of children in the US today are children of color. So this reflects what's going to happen and what we're going to see in the years to come. So basically, we are talking about what some have called the silver tsunami, the aging of the population, which comes together with the tsunami of chronic illness, because we know that up to 2/3, or actually over 2/3 of older Americans live with 2 or more chronic medical conditions. This is in the setting of a significant growth in diverse communities and minorities. And I think I can see this fellow here laying on the beach a little bit like our healthcare systems have been in the last few years, caught by surprise by what's coming upon us, which is a rapidly aging population, a rapidly diversifying racially population, and also plenty of chronic illness. And this is the setting in which suddenly COVID-19 strikes. So if we were not prepared well before, now we have an unexpected development that certainly has transformed everything, as we can all tell. And on top of that, another major phenomenon, which is the realization of the existing and generational structural racism that our country has been suffering from, also to just even add one more complicating issue. Some people were thinking that COVID-19 was called initially the Great Equalizer because it was going to affect people from all levels, all ages, all socioeconomic status and races. And we can tell now that this is clearly not what we are seeing, as we will go into here briefly. Just to remind you that unfortunately people of color are vastly disproportionately affected by poverty. The implication of the impact of poverty and other social determinants of health that contribute to poor health outcomes in minorities, is profound. These disparities are present in every corner of our country, and even on those states like Minnesota, which has one of the highest standards of care when it comes to healthcare. Minnesota has consistently ranked amongst the top states for many of the desirable markers of quality of life, healthcare, educational attainment, even reported happiness. I heard this recently that we are second to Hawaii as the happiest state, apparently, or at least we were when this statistic was done a few months ago. And yet, unfortunately, we also know that Minnesota is among the highest when it comes to disparities and inequities. And I think we all are becoming more and more aware of this sad reality. As of January 2020, Minnesota ranked 45 out of 51 states when it comes to racial integration, making it one of the most segregated states in the entire country. The state of Minnesota as a whole has the second biggest income inequality gap between blacks and whites in the entire nation. That's another negative for our state. Um, According to the most recent census data, the black poverty rate in the Twin Cities area was 25%, which is over 4 times that of the white poverty rate for our cities. And also, while about 3/4 of white families in the Twin Cities own homes, only about 1/4 of black families here in the Twin Cities do own a home. And this is probably due to that history of racial covenants and so forth that I think Dr. Banjoko will discuss with us more. The number of statistics could go on and on. You know, the incarceration rates for blacks in the Twin Cities area was 11 times that of whites. And actually, the state of Minnesota has the nation's worst education achievement gap between blacks and whites. I can tell you that Latinos in Minnesota in high school have the lower graduation rate in the country. So with this in mind, and unfortunate, inequities in our system, the Minnesota Department of Health has been working really hard to try to do something and combat these unfortunate realities. On top of all this, we have lived and in many places still living days of unprecedented social unrest, starting in Minneapolis and then spreading to the rest of the country and to many countries, as we all know, days of suffering resulting from the very topic we are discussing today, the disparities and at multiple levels and the lack of equity. Indeed, this social striving and unrest we witnessed these past months, it is the symptom. It's just the manifestation of the very lack of equity and the socioeconomic differences that the unequal privilege that the systemic racism that has plagued our society for centuries has led to. And as we mourn still the murder of George Floyd and others, unfortunately the list is long, as you all know. I'd like to share a quote by MLK, just to very briefly be reminded what he said back in 1967 when he was giving an address in Stanford, at the Stanford University, which is that in the final analysis, he was reflecting about riots. A riot is the language of the unheard. And what is it that America has failed to hear? It has failed to hear that the plight of the Negro poor has worsened over the last few years. It has failed to hear that the promises of freedom and justice have not been met. It has failed to hear that large segments of white society are more concerned about tranquility and the status quo than about justice, equality, and humanity. And so, in a real sense, our nation's summers of riots are caused by our nation's winters of delay. And as long as America postpones justice, we stand in the position of having these recurrences of violence and riots over and over again. Social justice and progress are the absolute guarantors of riot prevention. And I think this is a reality that hits so close to us here in the Twin Cities, and it's been so painful to see what we have experienced, particularly the unjust treatment of our brothers and sisters of the the Black community and other minority communities. But as you can see, this has been something that has been brewing through the centuries. And as a result, for example, when we look about life expectancy in the US, we see the marked difference in between different parts of the country, which is, very sad to see. We don't have to look at the US as a whole. We need to look at the mirror, look at ourselves, and realize that according to this report from the Robert Good Johnson Foundation from a few years ago, life expectancy in the core of our cities can be as different as 13 years, in between two neighborhoods that are only 3 miles away. So you are west of downtown St. Paul in the Frogtown area, life expectancy of 70 to 75 years. You go down west before you get into Minneapolis, still in St. Paul, life expectancy 83 years plus. So 13-year life expectancy difference in the very core of our cities. This leads to some people to say that our zip code is probably most important than our genetic code. And with that, I'd like to pass it on to Dr. Banjoko, who is going to continue to share with us a little more specifically about COVID-19. Thank you, Femi.
Thank you very much, Miguel. And I also want to extend my gratitude for the opportunity to present this information. I would go on to say the next slide here deals with missing data. In other words, basically the data we have is incomplete, and so one would have to take that into consideration. However, it's more likely that the data we have is underreported. Next slide. So according to this slide, you know that Black people are dying nearly 2.5 times more than white people are dying. And if you look at the slide, there's obviously self-explanatory. And obviously the racial breakdown is with, Black or African American suffering the most number of deaths at 93, followed by Hispanic or Latino, obviously closely followed by American Indians and Native Alaskan, and you see persons of color and other, coming down. Next slide. And the reason, excuse me, the reason why this is obviously more telling is that most Latinos and most people of color actually can't afford to stay at home for a variety of reasons, which we can go into later on, but one of which is, socioeconomic status, the kind of jobs they have. They're more likely to be frontline staff in most of the places that we visit. And so, next slide. And I think I'm going to spend some time on this slide because it really delves really deeply into the issues that we have. And this is sort of the age-adjusted race and ethnicity rates. And so if you look at the bar chart there, if you see the all cases above, and then the second the second row beneath shows the bar chart. And so the first column is for white Minnesotans. And if you look at the rates of death, is the lowest there, the rates of hospitalization in the ICU, and the rates of being hospitalized lower down. And if you go on next, you see that Blacks are actually, if you look at the all cases of COVID-19, 895 whites, Blacks 4,199, Asian and non-Hispanic 1,572, American and Native Americans and Alaskan 1,037, and then Native Hawaiian 4,162, multiple races 1,200, and then Hispanic 5,232. So you can see here that the rate of being infected and the severity of illness and the death rate is all higher for the ethnicity, and that is more remarkable because the breakdown sort of tells us that 25% of the population, particularly in different studies, would reveal the disparities that we see so glaringly. Next slide. So this brings us to sort of this, I would say, an interjection for me in my experience of what's happening, and that is particularly in the nursing homes. So in the nursing homes, I have a situation where, as Miguel had alluded earlier on, is actually the reality is playing out. So in the nursing homes, when you go visit the nursing home, you would find that almost 90% of the residents / patients in the nursing homes are white. But the caregivers, the frontline staff, the nursing assistants, housekeeping, laundry, kitchen staff, almost 90% minorities. And they tend to be younger, they tend to be recent immigrants, lower socioeconomic status. And I was sort of facing the two ends of the two fronts of the really high mortality rate, with having staff members in the nursing home who were being hit very hard with the COVID in their communities, being the same people coming to work to take care of the elderly, vulnerable, also hit very hard with COVID. And so it was quite a difficult thing to behold at that time, because not only did they know some of the things we find out is that when you ask the question, do you know anyone personally killed or who has died of COVID-19? Black population, about 31% of people know somebody personally who has died from COVID-19. 17% of Hispanics know someone personally, whereas only 9% of white Americans actually know someone personally who has died of COVID-19. So if you're not a person of color or minority and you're not elderly, for most parts, the COVID-19 pandemic is actually non-existent. And I think that highlights the disparities that Miguel was highlighting in the earlier slide. And the idea then is, we know that, communities of color are likely to have comorbidities, not just because of genetic predisposition. Obviously, as Miguel had pointed out, that the zip code is more determinant of that than your genetic predisposition. Then the question is, why is that? And that's due to the legacy of structural racism and institutional racism as well. So we have to distinguish this from, it's not about anyone's personal culpability in being a racist, but more or less the systems that underlie those racial inequalities and tend to perpetrate them. We can go to the next slide. So the risk factors for sort of most of what we're talking about here is obviously comorbidities, inequality in income, housing, and that includes, the so-called policies in place of redlining and restrictive covenants and, discriminatory lending and so forth, which tends to make diverse communities live in overcrowded rental, multi-generational home. And for COVID-19, that's a perfect brewing ground to spread and have worse outcomes. They have higher pollution rates, which also is a respiratory-borne issue that makes COVID-19 more deadly, so to speak. Employment, again, like I mentioned, frontline work, food production, meat packing, and so forth. And obviously, when you don't have a good paying job with benefits, then you can't afford to take time off work. You don't have sick time. If you live in certain situations, you can't quarantine. If you have to use public transportation, you don't have ability to do things online. And then obviously lack of health insurance or poor insurance. And of course, most importantly, fear and suspicion about care. We can get into some of that. And then the fear of reporting contacts. And for most people, the idea that you would avoid receiving care, that would seem strange, but for most communities of color, especially recent immigrants, that's a big problem. So when we look at community level factors, and we've mentioned some of that, the question now becomes, why is it that this thing is happening, and what can we do to avoid this? You can just, some of the rates that I would put out there is that Latinos and African Americans are hospitalized at about 4.5 times that of white Americans, and are dying at least twice as high. And most of the reasons we've outlined above, but most importantly is, after you control for everything else, minority populations, especially Black and Latinos, are more likely to get ill, and then are less likely to seek care, not because they're not taking the virus seriously. Indeed, communities of color take it more seriously than any other community in the US, but due to issues, particularly for recent immigrants, and this concept of the public charge rule, which the federal government began to enforce in February, which sort of says that if you sort of take on any public benefits, that you may be denied green card, visas, citizenship, and so people are actually afraid of that. And then people who have the so-called families where you have some undocumented members of the household, it becomes an issue when there's concern about all of that. And I think with that, we go on to Cristina for the next slide. So I would mute myself.
Thank you. But thank you for having me. It's a great pleasure to be here. And I'd like to talk a little bit about mental health, COVID, and disparities. And if you could show the slide. First of all, I'd like to start by saying that good mental health is critical to the functioning of society at best of times, and is more important in moments of distress, crisis, or moments such as we are living right now. The World Health Organization states that there is no health without mental health. And the reality is that in moments of distress, people who are at more disadvantages will experience more emotional and psychological distress. These numbers, for example, are just numbers of the general population, and they are from the CDC COVID-19 response report on June 2020. 30%, or roughly 31% of reported adults declare symptoms of anxiety or a depressive disorder. About 11% of adults consider suicide since the time that the COVID pandemic started. About 25% reported a traumatic or stressor-related disorder, and about 13% said that they were using substances to cope with the pandemic stressors. So in general, the population, many people are distressed due to immediate health impacts of the virus. Many are afraid of infection. Many are deeply affected financially, are facing economic hardships, and have lost family members. And although the pandemic is affecting the mental health of all individuals, not just in the United States, but all over the world, the reality is that the pandemic is affected differently those who are marginalized or those who are at more disadvantaged in society. So it's really important that we look at how that is happening and why that is happening. For example, if you think about immigrants and refugees that come to the United States or to any other country, they have a lot of adjustment difficulties and stressors that are looked at, and they look for community support to face those stressors. And with the pandemic and the COVID, the quarantine was necessary to stay away from communities. So we can imagine how that would increase isolation, and I'll talk about that in a little bit. But if we look at what we know from past disasters and public health emergencies, we can affirm that socially disadvantaged groups, racial and ethnic minorities, people with low income, will experience more emotional distress and more mental health problems than social advantaged groups. For example, the stress resulting from COVID related to financial insecurity, and this was data from the US Bureau of Labor Statistics, showed that between April of 2019 and April 2020, the unemployment rate increased from about 3.5 or 3.6 to 14.7 for the US as a whole, but from 11 to 32% among Blacks, and from 3.7 to 16.7 among Latinos. Another example of how COVID is affecting the mental health of disadvantaged groups is the effect of grief. And the unexpected death of a loved one is a risk factor in general for mental health. But among bereaved individuals, the prevalence of prolonged grief, that means the prolonged grief disorder, where there's characterized by persistent yearning and preoccupation with the person who's gone, the deceased person, is estimated to be nearly twice as high among African Americans and non-Hispanic whites. Another survey that I would like to mention is done by the American Psychological Association. The Harris poll for the APA looked at the mental health effects on parents of children who were schooled during the pandemic and they had to stay home. Nearly half of the 3,000 mothers that were questioned reported battling severe daily stress, according to this Stress of America poll, and 7 out of 10 admitting having problems doing their own personal work and juggling their children's homeschool work. Also, people of color were more likely to report higher stress related to the coronavirus. 4 in 10 Hispanics said that they often or constantly felt stressed out. The restrictions that were imposed by COVID were very necessary and preventative in nature, and they were very painful. But they have had consequences, some benefits, because they have kept many people safe. But the fact is that they have created what we call the loneliness epidemic. In 2019, the Health Resources and Services Administration described this as an increase in societal concern. And Cigna produced a report that identified Hispanics respondents, about almost 48%, and those who identified their race as other were the loneliest, followed by Black African American respondents with 46%. And if we think about a resource and a protective factor for mental health problems is community and being in contact with others and being in relationship with others. But communities of colors and immigrants have experienced higher levels of loneliness associated with this physical distance that we had to participate in due to COVID-19. Many health experts equate social isolation to obesity, smoking, lack of access to physical activity. So these we can see how the effects of COVID have really impacted the mental health of communities of color. Throughout COVID, I've heard the phrase that we are all on the same boat, that we're all in this together, that we are in the same boat when we think about COVID. But as Dr. Ruiz and Dr. Olufemi was talking, we are not in the same boat. We are in the same storm, but we're not all in the same boat. Many people do not have the same resources. And I would like to point to this family stress adaptation theory in the slide that was developed by Pauline Boss and colleagues. And it's really helpful to look at what has happened in the mental health of communities of colors and low-income communities in the midst of the COVID pandemic, the double pandemic that Miguel was talking about before. If you look at the stressor, in this case, COVID, it is not really happening in isolation or in a vacuum. The stressor is happening in the context of external, cultural, historical, economical influences, as well as structural and psychological and physiological influences. So as families and individuals are faced with the stressor, they are facing the stressor in the context of these two big influences. And the stressor or the event or the situation will create stress or crisis depending on how the family perceives the stress and the level of resources. And I was saying that we're not all in the same boat because we don't all have the same set of resources, financial resources, emotional resources, societal resources. And the research shows that the lower the resources, the harder it is to have a positive perception on an event or situation. So it's harder to reframe and to find the positive out of the events that we are living if the resources are low and the external context is putting a lot of pressure. And that's where we go from stress to crisis. And this is a lot of what I have been seeing in my patients that have experienced very high levels of anxiety, depression, and levels of very difficulty managing stress. So what can we do? It is very difficult to talk about what to do, and often we speak of resilience. And I would like to propose that we move from that individualistic view of resilience as the capacity to rebound from adversity, strengthened, and be more resourceful as an active progress of endurance. This is a really valid definition. I think is really important, and it can be harnessed and it can be activated through self-care. But I would like to move to the idea of collective resilience, understood as the bonds and networks that hold communities together and provide support and protection and facilitates recovery in times of extreme stress and crisis as we are living right now. So as mental health providers, what we have seen is that the effects of isolation have increased mental health struggles and disparities and problems, and isolation has exacerbated them. So it's really difficult to grow individual resilience when you are by yourself. So what can we do to foster collective resilience if we need to be physically distant? And this is the part that we need to be creative about, challenging power imbalances, and we'll talk a little bit more about that, but begin to conceptualize the ability to support others as a collective effort, not an individualistic effort, to support families, to help children have a sense of warmth when they're studying by themselves in the house, and to really think creatively how to utilize the community resources to help the mental health of individual. Is a collective effort in order to have collective resilience.
Thank you very much, Cristina. That was great. And you asked a couple of times. Can you hear me? Yes. You hear a couple of times, what can we do? Well, that is, I think, a question that we are all asking. This picture is that of actually our daughter, who is the girl on the right side of the picture, in South Minneapolis, 2 days after the most violent riot night in the city, cleaning the streets, following that destruction and that difficult nights. And what comes to my mind when I see this picture that Cristina took is that we're on this together. That's the only way is we would if we do this as a team. It's time to move from talking and observing to taking action if we want to see more health equity and less injustice. So some local authors from the University of Minnesota, and actually also Park Nicolette, on an editorial after the murder of George Floyd, they were having a reflection on what was happening and the impact of racism, and they end their reflection in the New England Journal of Medicine with this sentence: any solution to racial health inequities must be rooted in the material conditions in which those inequities thrive. Therefore, we must insist that for the health of the Black community, and in turn, the health of the nation, we address the social, economic, political, legal, educational, and healthcare systems that maintain structural racism. Because as the COVID-19 pandemic so expeditiously illustrated, all policy is health policy. So at Health Partners and Park Nicolette, we have been thinking, what can we do? And we've been actually reflecting on the concept of cultural humility now for quite a number of years, realizing that as providers, as nurses, doctors, social workers, other personnel, what can we do, counselors, what can we do to help our patients who are from different diverse communities? And this is the framework that we seem to feel works best, is the framework of cultural humility, in which it is really emphasized the fact that it's not about cultural competence, where one can have the feeling that I got it, now check mark, we understand, we know. It's actually the opposite. It's really understanding that we don't know, and it's an approach in which we always need to come to these issues of culture, race, and disparities from the humus. Yeah, the stuff that we eat, humus, which is the Latin word for soil, and it's the humus, the soil of our common humanity with our patients, with our partners, human beings from different races, from a position of humility. As we think about what action we can take, we propose that one could align into action and move into action following these basic pillars of cultural humility, which are realizing that this is a lifelong journey of learning and self-reflection and challenging assumptions. Is about identifying power imbalances and doing something about them, acting on them, and it's also about developing partnerships and challenging individualism. And I think we're going to just spend our last few minutes touching briefly in each one of these ones, and I am asking Dr. Banjoko to start with the first one.
So I unmuted now. I think I'm on. Yes. So a lifelong commitment to learning. And I think the first thing is, to look in the mirror and understand that we all have our biases. We all have things that we hold as truths, and they may or may not be necessarily so, but they're shaped by our experiences in the world. So being able to look in the mirror and challenge that. Be curious, always ask questions. The assumptions we bring to the table are often not always correct. And I think asking questions and also being able to state that I simply don't know when it comes to certain questions that one might get asked or one might be faced with, knowing that one doesn't know and accepting that as a fact is also helpful. I think one of the big things is to be okay with discomfort. I think in the United States, we are quite uncomfortable discussing race and racism. And as a result of that, we avoid the topic. And as a result of that, we rather discuss poverty, we would rather discuss social and economic status, but we do not get to the root of the problem, which is the racism and structural issues that have been embedded in all our, be it from the justice system to the healthcare system to the educational system. And so I think one of the things there is to be okay with the discomfort of this. Suspending judgment. I think most of the time when the discussion of race and racism or minority issues come about, people often want to offer their opinions and pass judgment on the situation based on their backgrounds, and we're all guilty of that. I think develop trust, and there's no two ways around trust. It has to be earned, and it takes a lot of time and commitment. It's not something that one act would bring, but it's certainly something that one act can destroy. So you can spend years and years of building trust, and one act can lead to mistrust. I think a couple of things I would mention here is, you know, the deconstructing white privilege and sort of the concept of being an anti-racist. And many people would say, well, I'm not racist. And unfortunately, there isn't a, you know, it's an issue of you can't be on the sidelines. We have to all be all anti-racist, otherwise the systems and the outcomes would persist. And people would ask why. Well, I would just bring you back to the numbers that Miguel initiated. Is why do we all have to deconstruct white privilege and all be anti-racist? Is because, one, children less than the age of 18 years old currently in the United States, greater than 50% are minority. And I think that number by 2030, people less than the age of 30, greater than 50% will be minorities. So as we all age, if we continue with the systems we have in place to produce the outcomes we have, we can see how untenable as a country this would be when you would have such outcomes in over 50% of your population. Obviously, that is not something that's sustainable for the health of everyone in the country.
Thank you, Femi. And so lifelong commitment to learning, to self-reflection, to self-criticism, to looking in the mirror, to mindfulness, very important in healthcare, very important everywhere. The second principle or tenet or pillar of cultural humility is identifying power imbalances. And this is really, this requires for you to be on the watch. It's like Femi just said, not on the sidelines, but being sensitive, being mindful, being perceptive of the situations. We see this in medicine every day. I enter a room to see a patient with oftentimes with my residents, and we are there and we're standing and the patient is laying. We are feeling well, the patient is sick, power imbalance. We may be, we are well dressed. We got our coats are on. Our patients are almost semi-naked with a hospital gown. Some of our patients don't speak the English, and we say, well, they don't speak English. We should be thinking perhaps we don't speak Somali, and there's a clear imbalance there that we really need to be aware of. So we need to just be cognizant of acknowledging microaggressions that happen every day in our clinics and hospitals, and you know, that are part of this disparity and this racism that we are talking about that exists in healthcare and everywhere else. That's why we need to learn how to earn the trust that Dr. Banjoko was saying. I like this learn mnemonic actually for this is what we teach some of our residents on intercultural communication. And I want to say that L is for listening. And without listening, we don't have the rest of the word. We don't have the earn part. We need to, first and foremost, really try to seek to understand before we can be understood. Try to put ourselves in the place of our patients, and then we can explain. That's the E. Then we have to acknowledge what they explain, acknowledge the reaction that our patients do have when we explain, and understanding that acknowledgement cannot be one of judgment, but rather one of curiosity, one of wanting to know, what do you think caused your disease? Why do you think this is happening? What would you do if you were in your country of origin, and so forth? Only then, when we have listened, when we have explained in detail and at their level and with an interpreter if they don't speak English, and when we have acknowledged, is that we can recommend our treatments. And then comes the end, which is to negotiate, not just what we want, but also humbly also negotiate what is making more sense to them. In my opinion, I think one of the keys for challenging these power imbalances in the clinical practice is to find elements in which you are actually at the same level of the patient or even below the level of the patient. So I remember years ago, when we were struggling with our teenager children, I will be taking care of a patient in the hospital, and it'll be a nice point of connection when I will realize that they have older children than us, and I will be asking for advice. So you have your teenagers, and how did you manage parenting is such a difficult thing to do, and really asking them for advice. Or you have a common hobby, you both like certain sport, be able to connect with our patients in things, in items in which we are not above, but when we are at the same level. So I think this is what identifying power imbalances, which, by the way, we are talking about the patients, the clinical room and the hospital, but this obviously exists in all levels of society, in all environments, and no matter what you do for a profession or your occupation or in your neighborhoods, always be keeping in mind. I tell sometimes our residents, before we go in the room, let's think about this for a second. It's like a timeout. Let's think. As we go in the room, let's try to be attentive. What kind of power imbalances are you able to pick up? Maybe as simple as I'm standing, you are laying, I'm going to grab a chair so that we can be at the same eye level. It can be as simple as that, and those things go a long ways. And the third pillar of cultural humility has to do with developing partnerships. Cristina.
Yes, the third pillar of cultural humility is developing non-paternalistic partnerships. And this can be done at the individual level, but also at the institutional level or collective level. And one of the important parts of developing non-paternalistic partnerships is to really work with our own organization's health equity program. So if we are working for an organization and we don't know if the organization has an equity program, ask our supervisors or our superiors and inquire what is the organization doing as a whole to really stand in the gap and to really move into the arena of being actively, as Dr. Banjoko was saying, to be actively anti-racist. Also engaging with community partners and champions for the long run, not just for small projects, but really engaging in partnerships where we can work together and see the results perhaps for a generation or two. And this can be done again at an individual level as well as a collective level, and increase the level of civil engagement. As organizations and as person, we have an opportunity right now like we haven't had before to really be involved at a civil engagement level, at a local level, at a national level as well. Before we finish, I would like to read a quote by Parker Palmer, and then I would love to hear from Dr. Banjoko and Ruiz before we wrap up. But it really is difficult to hold hope, and very difficult when we are holding such mountainous challenges. But hope is holding a creative tension between what is and what could and should be, each day doing something to narrow the distance between the two. And I think that having conversations about difficult topics, as Dr. Banjoko was saying, talking about race and inequity, is one small step towards doing something to narrow that distance between those two.
Thank you, Cristina. Actually, I don't know if it was the first time, but certainly the last time I was visiting Westminster Presbyterian Church in Minneapolis, we were listening to Parker Palmer when he came on a Sunday morning, I think it was, and shared some of his wisdom. So this quote, which I think is so beautiful, reminds us of that time we were there in your place. So thank you again for having us. And I think this is the time where, if you have any questions, we would love to see how we can address them.
So that was very excellent. Appreciate your perspectives on all three of you. I have one question directed to Cristina on the topic of risk factors in relation to housing. Are there any known Minnesota programs that assist in mental health for those experiencing homelessness, for trauma, addiction, or loneliness, etc.?
Yes, there are lots of programs, and I wish I would have known to have the list ready for me. Housing is certainly a big problem. We have a problem to provide dignified, stable, good housing for our communities, and particularly for communities of color. So if it's okay with you, Michelle, what I will do is provide a list and add it so we can add it to the resources perhaps at the end of the presentation.
That would be wonderful. Thank you so much.
Yes.
So a second question I'd like to direct to Femi, and it is many primary care clinics, and also anybody else who can chime in, and mental health programs have made progress in providing ethnically and racially informed patient care. How might similar progress be made in cardiology, oncology, and other specialty care programs?
Thank you for that question. I think what I would say is there's one thing to distinguish between the programs that are done at the patient to doctor level and then the barriers from a systemic standpoint. So while I can provide racially competent care to my patients individually, I'm providing that care in the context of a healthcare system that has some built-in inequities and obviously starting from things that we never think about, the hours of the clinic operation. So it's the same working hours for folks who can't take time off work. They're expected to do certain blood work at facilities that may not be accessible by public transport. So those are some of the things that are outside the scope of what we do. So there's the one aspect of the individual being able to go through the steps of providing, competent care in a empathetic, culturally competent way. But also then there's the system within which we practice. So obviously it has to be a both and. Both the individual providers and the team members in the team would have to be able to provide racially competent care, but also the systems would have to be changed in such a way that we would have to address systemic issues as well.
I agree with those comments, very wise. And just to give you an example of such an effort, for example, I know Health Partners, specifically Regions Hospital, has a community paramedic program in which for some of the patients with, for example, chronic heart failure, talking about cardiology, some of whom have a difficult time with accessing care because of transportation issues, we can actually have the community paramedics go and doing after discharge from the hospital checks on these patients, being able to draw some labs, and therefore bypassing many of the barriers that some of our patients have. And this is a group of patients many times that are what we call dual eligible, maybe Medicare and Medicaid recipients that tend to belong to lower socioeconomic status groups. And you've got to get creative with these programs. Yeah.
I do appreciate you sharing all of you share your perspectives. And so we would like to close for now.
Well, thank you very much for having us. It was a pleasure sharing with you, and yeah, all the best. Thank you for your work in your forums and your social activities, okay?
And thanks, Michelle and the entire team. We really appreciate all your efforts. Our next forum will highlight Westminster's longstanding commitment to affordable housing in downtown Minneapolis, and we'll be featuring a panel that includes our partners from St. Olaf Roman Catholic Church in downtown Minneapolis and AON. Please stay tuned for that.